Happy Wednesday, everyone. I hope you're all enjoying this nice stormy weather that we're having today. Thank you all so much for joining us this evening. And if you're looking to learn more about osteoarthritis and ways to relieve your knee pain, you're in the right place. And we've got a ton of great information to share with you. I'm Olivia with Ethos Integrative Medicine. I'll be moderating this webinar. Before we start, please remember to keep your microphones muted. If you have any questions, feel free to type them into the chat. We'll be sure to answer those at the end. If you have any specific questions pertaining to your personal care, we cannot address that in this webinar, but I highly recommend scheduling a free 15-minute consultation with Dr. Matt, and he'll be able to answer your questions and help you to navigate those treatment options that are available to you. So I'll go over more information in the end for this. First of all, I'd like to start off our webinar by introducing our regenerative orthopedics expert and men's hormone specialist, Dr. Matthew Hernandez. He believes that when patients live pain-free, they're able to live their life to the fullest. His key to success is combining a comprehensive plan, cutting-edge image-guided treatments and collaborations with other providers to get patients results and help them to live an active lifestyle pain-free. Today, he'll be diving into what knee osteoarthritis is, how it develops, and how regenerative medicine can improve osteoarthritis. So we're super excited to have Dr. Matt host this webinar. I hope you all get the chance to connect with him. He's got a ton of resources to educate and help individuals stay active, take care of their health and mobility, elevate their mindset, and achieve optimal performance. So without further ado, I'll let him get started with his presentation.
Thank you so much for the introduction, Olivia. Thank you all for being here with us today. This presentation today is going to be going over osteoarthritis. It's going to be going over the treatments that are done in the conventional model of medicine and going into some detail about how effective those treatments are, and then looking at other options outside the box that patients are often seeking for treatment of osteoarthritis. So we're going to be discussing all that today, and we'll go ahead and get started. Right before, so just to start off, I'm going to tell you a short story about Janet. So Janet is a patient of mine, and she's given me permission to use her story. And what Janet, several years ago, it was about 5 years ago, I believe, was going and working on competing in a bodybuilding competition. So she was training to compete in this bodybuilding competition. During this training, she started experiencing knee pain. And Janet at the time, I believe, was 60 years old. And so she was going and training for this competition. One of her lifelong dreams was to go in and be in a bodybuilding competition. And so she's training, starts experiencing knee pain to the point where it's stopping her from being able to train. And so she went over to the doctor, her primary care at that time, and said, hey doc, I'm having some knee pain. It's stopping me from training. What can you do to help me out? I can't go in and do the stuff that I like because this is really holding me back. So the doctor went and ordered an MRI, and this is what the MRI read. It was tri-compartment loss arthritis, and especially severe in the lateral compartment. So basically, arthritis all throughout the knee. She had some meniscus injuries, different things like that. And she said, okay, doc, thanks for the MRI. What can I do to fix this? And his response was, oh, Janet, you're 60 years old, you're active. This happens as you get old. You're just really going to have to stop working out, and you're going to have to start taking it slow. And Janet was left really deflated after that piece, and really going and asking herself, will I really have to live with this like this for the rest of my life? Do I need to stop being able to train for my competition? She's also a personal trainer by trade as well. So, she had to, that meant that she's not able to work out with her clients anymore. Is this really part of me getting old? And will I ever be able to get back to the stuff that I love again? And these are questions that get asked to me by a lot of patients. And so Janet came in asking these exact questions again. And so we're going to go over what her journey, may have looked like had she gone down a conventional route versus what it did when she went down the Ethos route of using our approach to osteoarthritis. And so we're really going to go in and highlight those two different approaches and see ultimately what Janet's outcome was at the end. Um, just a little bit about me. What why are you listening to me today? Do I really know what I'm talking about? Those are all important questions to be asking yourself. And so a little bit about me. I graduated from the Southwest College of Naturopathic Medicine. So I'm a naturopathic physician, and I primarily specialize in sports medicine and men's health. I'm the co-owner of Ethos Integrative Medicine. I host a podcast called the Ethos Athletes Podcast, and on there we give resources to help people stay active, learn about their health, really take control of it. I do train other medical providers in regenerative medicine, which is what we're going to be discussing today, or part of what we're going to be discussing today. And most importantly, I work with active individuals to help them stay active and enjoy their life. Many people like Janet, and really just allow them to go about enjoying life, being able to do the stuff they love to do. In 2018 and in 2020, I was voted a Phoenix Top Doc by other peers. So this is a physician vote where other doctors vote for the top doctors within the city. So I was fortunate and very grateful to win or to get voted on those 2 years. So going into what osteoarthritis is, the general consensus in the medical world is osteoarthritis is a breakdown of cartilage that leads to pain. And so if you look at some pictures here, on the top, we have healthy cartilage. Everything looks smooth. The cartilage is the smooth white part. And then you have grade 2 osteoarthritis. I use grade 2 just because it's enough to show you what this looks like. You can see the cartilage is degenerated to some degree, and it's kind of being worn down. And so osteoarthritis, by definition, is a breakdown of cartilage that leads to pain. And in more research is showing that there is a failure to repair that can be due a repair of this cartilage that can be due to biomechanical, biochemical, and genetic factors. And as osteoarthritis progresses, it essentially starts to affect the entire joint. So the entire joint becomes painful, and then you start having failure of not only the cartilage, but the meniscus, like in Janet's case, ligaments, different things like that. And so it does have this compound effect over time. And so those are some things that you really need to pay attention to. So how do you know if you have osteoarthritis? One of my pet peeves with this particular condition is it is often a diagnosis that's given right off the bat. I've seen a lot of patients who go into the doctor, they're told they tell the doctor I have knee pain, and right away, without really doing an exam, without really understanding what's going on, they're told they have arthritis. And it's kind of this catch-all term that we use, and we're going to see why that's used with the approaches we're going to be discussing today. But it becomes this catch-all term, and unfortunately, when you go and generalize stuff very much like that, the outcomes for treatments are very poor, and the patient results are very poor when you classify everything as a catch-all. So that's one of my pet peeves. So I want you to understand what osteoarthritis actually looks like. And so how do you know if you have osteoarthritis? You're going to be experiencing pain that's typically worse with joint use. So it's usually a little bit bothersome more at the end of the day. It's relieved by rest. You can usually have tenderness around the joint itself and stuff. So if you go and push along what's called the joint line where the two bones meet, you start to feel a lot of pain in that area. If you have a Chondromalacia or Patellar-Femoral arthritis, which is arthritis behind the kneecap, that is typically, the way that typically presents is it's worse when you're sitting for a long period of time. When you're standing up from a low chair, you start to feel knee pain, especially in the front of your knee. And then when you go downstairs, that really aggravates people. And then it can also aggravate when they go upstairs as well, but downstairs is the more key finding in general. You can also have pain on the inside or the medial side of your knee. So in between your legs on that side, that's where the second most common one is. And so that's another side of knee pain. And then the further the pain travels, typically the more advanced the osteoarthritis is. So sometimes people come in saying they're having calf pain, and in reality, they're having arthritis in their knee, and it's just so progressed that they're feeling it in their calf now. And so that's something to definitely pay attention to and examine. If you're waking up when you sleep at night due to knee pain, there's a good chance that you might have that. It could also be meniscus issues, stuff like that. So there's some things to tease out when, as a provider, when we're really evaluating someone. So those are all different things to to look at for that part. So the conventional model, I think, does a decent job at getting people out of pain. The issue that a lot of patients have is that they typically want more than just pain relief. They want to be able to have function again. They want range of motion. They want to be able to go and be active, do the things that they love. And although some pain relief can help them do that to some degree, ultimately, with what we're going to see with a lot of the traditional or the conventional model treatments, is that we're over time just making the issue worse. And so focusing on the wrong goals is one of the main problems with the conventional model. And again, the main goal in this case is really just focusing on, can I decrease pain? And so there's lots of ways to do that, but not all of them are long lasting, and not all of them are, at the end of the day, fix the problem. It's more of a Band-Aid. And so that's where Band-Aiding the problem comes in as well. There's a lot of treating with blinders. What we're going to see throughout this presentation is a lot of the treatments are focused on the cartilage of the osteoarthritis, which is good to some degree, but there's some more recent research that's showing that it's more to it than just the cartilage. And so we'll go over that. So treating with blinders and just focusing on the cartilage is the wrong approach. And then treating with outdated therapies. And again, this goes to, really going and understanding what the treatments can do, and tying that to their effectiveness and what the goals are overall. So we'll go, those are the issues I have with the conventional model. And let's go ahead and dive into that so that, we can really tease that information out. Everything that we're going to be presenting for the conventional approach is taken from the osteoarthritis algorithm of how you approach osteoarthritis as a orthopedic surgeon, as a primary care doctor. If as many of you likely know, medicine is very algorithmic based. So it's very much, do they have this condition? Start with this. If that didn't work, go to this. If that didn't work, go to this. And so all the stuff here that we're going to be discussing is we're basically going to be walking through what the algorithm looks like. That way you can see what it looks like from that model and understand how physicians in the conventional model think. So this very first one, let's go back to Janet. Janet has been having osteoarthritis, and she goes back and goes to her doctor. They diagnose her with osteoarthritis, and the first thing that they typically tell you is that you need to start with non-pharmacologic therapy. And we'll go into what that is in a second. And so you start with non-pharmacologic therapy, and you wait 3 months to see how you respond to that. That's what the algorithm tells us to do. So non-pharmacologic therapy, first off, is exercise. Now, if you've been a patient of mine in the past, or if you've heard me speak in the past, I'm a very big advocate for exercise and physical therapy and making sure that you're doing weight training to strengthen various muscle groups throughout the body. The knee and osteoarthritis is no different. There's typically a lot of issues with weakness in the hip that cause osteoarthritis. And so exercise and making sure that those are strong are very important. And so this is one of the first things that is in the algorithm that I completely agree with, is making sure we do this part. Now, what this study shows that was done in 2015 was that the people that had knee osteoarthritis that used land-based therapeutic exercises had a short-term relief that sustained for 2 to 6 months after the formal treatment. So they did physical therapy, they got relief, and then it worked for 2 to 6 months as long as they continued the treatment. There was a follow-up study that I didn't list here, but the follow-up study basically showed if they continued exercise, then they continued noticing benefit from it. Now, not all of these people had 100% relief, but a lot of them did have a significant decrease in their pain overall and improvement in function. So Exercise, fantastic first line therapy. Doing that's going to be really important, especially if it's a mild case where there's not a lot of tissue damage. You're really going to respond to that treatment. The other one is going to be weight loss. So weight loss, again, I'm a big advocate for patients who may be overweight and having osteoarthritis. There is not only a lot of doctors focus on the mechanical stress of carrying the weight on the knee. That is important. Yes, there is a biomechanic component to it, but even more research has been showing that the fat cells that are in the adipose tissue. So if you have more adipose tissue, you're going to have more fat cells, right? These fat cells will go and release cytokines that actually damage cartilage and increase inflammation in synovial fluid, which is inside the knee. So those fat cells will release these signaling molecules that actually worsen the osteoarthritis. So being able to decrease your weight and lose weight will actually help improve that significantly, because you're not going to have a release of those signaling molecules. So again, fantastic component fantastic first start to being able to work with that. So in Janet's case, so let's go back with Janet. Like many of my patients, Janet is an active individual. So exercise she's already doing, weight loss she's already fit, so she doesn't really have weight to lose. So now Janet was told, do that for 3 months and see what happens. So now she's at step 2, right? And at step 2, she's looking at topical pain relievers. So topical pain relievers are then supposed to be prescribed, and then as a doctor, you're supposed to wait 3 months before you reassess to see if the topical pain relievers worked. So when we're looking at pain relievers, there are topical Nsaids that have been shown to improve osteoarthritis pain and decreasing the pain levels. The most the most effective one was diclofenac. Topical diclofenac put over the joint can help decrease pain levels as a whole. And it says here, it can provide good levels of pain relief beyond carrier. Carrier in this case is another word for placebo in osteoarthritis. The issue that we have is that it worked for a minority of people. So it really, it did help some people, but not everybody. And it was actually a very small percentage of people that responded to topical NSAID use for osteoarthritis. So after we've gotten rid of exercise and weight loss, our next best thing, or the next thing in line, is topical pain reliever, which doesn't really show much efficacy. If you do want to try it, the best one in general is diclofenac, but obviously ask your provider to make sure you don't have any contraindications for that. But overall, didn't work super great for people. Another arthritis topical pain reliever that you can use is capsaicin. And so with this one had a little bit better improvement. So 80% of the patients that were treated with this did have a reduction in pain after 2 weeks of treatment. The issue with this one is that it does have a burning side effect. And so it shows that 2 patients withdrew because of the side effect from that burning. And overall, it's a safe and effective treatment to decrease the pain. Again, remember, the goal is decreasing pain here, not necessarily focusing on function, all that other stuff. After 3 months of no permanent relief from topical pain relievers, now we're jumping to Nsaids, right? And so when we're looking at Nsaids and opioids, this is the next step. Again, you're supposed to give this, wait 3 months, and then see what happens as a provider. So for Nsaids, this study showed that there is some improvement. Again, diclofenac we can see is the most effective NSAID, just like it was in the topical. The safety profile for this in the long-term use isn't great. So again, you want to stay on NSAIDs for less than 3 months. Otherwise, you can start causing liver damage, kidney damage, all this stuff. And so even though it did decrease the pain, it didn't provide permanent relief. And ultimately, the side effect profile for this was going to be poor. In the algorithm notes, it does say that if a patient starts to get GI symptoms from chronic NSAID use, to give them a proton pump inhibitor to help those GI symptoms. So just adding another medication to the list of stuff for you to take, which ultimately at the end of the day is still giving you short-term relief. PPIs or proton pump inhibitors are probably one of the worst medications you could be on because it impacts so many things. But it's recommended in people who have symptoms from NSAIDs. And then opioids, if you can avoid this at all costs, I definitely would. I put this in here just because even in here, this study shows that opioids are no better than NSAIDs for managing pain relief. And the side effect of these is obviously like dependence on it and addiction. And so I put this in here primarily so that people are, if you know anyone that's on these for osteoarthritis, they should probably be seeing a different doctor because this is actually really poor medicine. This is actually against what the algorithm says. So they specifically say, do not use this in the algorithm. And so some doctors are still old school and they still might be doing it. I just put it in there just so if you know anyone, they should probably be changing care. Just because you don't want them having an addiction to this. It doesn't outperform NSAIDs. So just be aware of that part. So again, after another 3 months of no successful therapy, and Janet did these things already, the next thing is duloxetine. So duloxetine is actually really interesting. So duloxetine is a antidepressant, and it is a serotonin norepinephrine reuptake inhibitor. Now, there's good research that shows that you can go and use these medications, specifically an SNRI, to help manage pain related to nerves. So this is where the algorithm gets a little interesting for me. Not that I want people to be on an antidepressant for their osteoarthritis, but what this part shows is that they are starting to think a little outside the box within the algorithm of the conventional model. So again, duloxetine is an antidepressant that can be used to treat nerve pain. So by going and prescribing this, a doctor is saying that your pain may be related to nerves. Your osteoarthritis might be related to nerve, not necessarily the cartilage. That despite you having cartilage damage, it could be being generated from a nerve. Now, it's good to see that because now they're starting to take the blinders off just a little bit. And in this case, what we're interested in is, okay, nerve pain, like how is the nerve pain causing my osteoarthritis? So there's a research article that was published in Science News. And basically what this article said was their research determined that when you have arthritis in your knee, there are pain signals that generate from the nerves around the knee, and those signals get sent back to your spinal column. The signals can then cause arthritis within the spinal cord. And those signals that are the arthritis in the spinal cord can then go back and affect the knee. And so there's this two-way communication of this nerve pain that's going on that's actually making arthritis worse. And so we can see here, it's revealed pain signals originating in arthritic joints, and these biochemical processes of those signals as they reach the spinal cord worsen and expand arthritis itself. So by taking duloxetine, you could argue that you're stopping that nerve pain, which is then stopping the arthritis from progressing. Now, the issue with this is that you're still taking an antidepressant. So you have all the side effects of an antidepressant, which isn't great. But they're thinking a little outside the box with understanding that arthritis just isn't a cartilage problem. There's more to it. And so this is the, one of the instances that we see that. So another piece on nerve pain, there's two studies that were published. So the nerve osteoarthritis pain and the existence of neuropathic component in patients with osteoarthritis of the knee. Both of these research articles basically went and determined that there is a neuropathic or nerve pain. Neuropathic is another word for nerve pain, essentially, that is causing issues with osteoarthritis. And so it is contributing to that. And going back to the Science News article, having those signals is going to continue to worsen arthritis as a whole. So it's an interesting thinking, like outside the box approach, giving duloxetine. Again, the downside to it is it's still an antidepressant, so you still have the side effects for that piece. But nerve pain is definitely something to consider when you're looking at osteoarthritis as a whole, and we'll see a little bit more stats on that later. So now Janet has gone down another 3 months. So at this point, she's done 3 months here, so 3, 6 months, 9 months. And now we're at 12 months of still having knee pain, not really going and getting better. And we're looking at adjunctive therapies now. And if you're wondering what this is, it's technically a CD player, but it's the closest thing I could find to a TENS unit. So if you're wondering why is that guy carrying a CD player, you are correct on what that image is. And so looking at adjunctive therapies here, the adjunctive therapies mean a few different things. So one of them is going to be a TENS unit. TENS unit, this study shows how a TENS unit, or looks at the efficacy of TENS unit for osteoarthritis, and basically says that it's inconclusive, and that it wasn't really, they couldn't confirm that it worked for pain relief. In the algorithm, they say that you can try TENS unit, but the success rate for it is pretty minimal. So we know TENS unit doesn't work as an adjunctive therapy. This next one is one of my favorites, is hyaluronic acid injections. So this is another one that is a very, I like this one a lot because it's still very traditionally used. And within the algorithm, it actually says not to use hyaluronic acid injections, and they don't recommend it because it is it doesn't outperform anything really. So hyaluronic acid injections, this is also, if people talk about getting gel injections in their knees every 3 months or something like that for arthritis, this is what that is. And so traditionally it was very heavily marketed by the companies that made it. You'll see here that in this study, they said that the overall effect was greater, but was biased towards stronger treatment effects because of the influence of non-blinded and improperly blinded trials. So basically, this meta-analysis of hyaluronic acid found that a lot of the research behind it was actually pretty biased and wasn't compared properly with other treatments. And even at the end of the day, it didn't show any clinically important differences between hyaluronic acid over placebo when they looked at all these different studies, and they took out the biased ones. So hyaluronic acid, again, is super common for osteoarthritis treatment. A lot of doctors continue to do it today, but within the algorithm, it's actually they actually say don't use it anymore because there isn't any efficacy for it. It doesn't outperform placebo. It doesn't outperform Nsaids. So there's really no point in continuing to use it, even though it's still widely used in the conventional model. So that's to me that's always that's interesting. Just not a lot of doctors have caught up with that update, I believe. So this time now they've done, Janet went through adjunctive therapy with hyaluronic acid. Those treatments are done once every 2 weeks for 3 injections, so 6 weeks total. So now we're 6 weeks down the road here on top of the 12 months that we've been dealing with this. Now we're looking at intra-articular glucocorticoids. So this is a steroid injection. Steroid injections are really interesting for the treatment of arthritis for a number of reasons. One is they provide short-term relief, and within the algorithm they say this is like literally the goal of this injection is to give short-term relief, and you cannot expect relief really greater than 6 months for sure. You're probably going to fall somewhere short of around 3. And in this study here, done in 2015, intra-articular glucocorticoid for knee osteoarthritis, we are looking at, they found that multiple time points that suggested that the effects decreased over time. Our analysis provided no evidence that an effect remains 6 months after a corticosteroid injection. So this didn't really show much improvement outside of 6 months, and it does decrease pain a bit, but it was still pretty minimal. This particular one compared a few different things. So They looked at steroid injection versus saline and what it did to cartilage volume. So keep in mind part of the issue that we're having here is that cartilage is being degraded in the knee. And here we learned that when you're using a steroid injection, that resulted in significantly greater cartilage volume loss and no significant difference in knee pain when compared to saline injection. So not only did we not see an improvement in pain, we saw a decrease in cartilage volume. So now the cartilage is shrinking as you continue to use steroid injections. So it's actually compounding the problem and making it worse. And so that's some of the info on intra-articular glucocorticosteroids. And so again, decreasing pain is the goal of it. It's lasts short term, and so the other issue with steroids is that you're also going to have a lot of side effects should you continue to get multiple. You're not supposed to get more than 3 in a year because then it starts to mess with your blood sugar, your endocrine system, all this other stuff. So now Janet is left after the steroids have failed. Janet is left being told that she needs to have surgery, but she's not a strong enough candidate for surgery. So she has to wait until her pain is persistent and disabling. And that is when she will then qualify for surgery. Well, Janet's barely active. She can still do squats. She's still functional, but she can't go and, she's not disabled yet. She's not using a walker like our person here, a cane like our person here. And so she's not a candidate for surgery. So basically patients in this, after they failed these therapies, they are basically stuck waiting until their knee pain gets worse enough and their arthritis gets worse enough to that where we can justify surgery. And that's where a lot of people will come and end up in my office at this point of saying, hey, I've done all these things. I was told I'm not a candidate for surgery. What can I do at this point? Because, I don't want to have surgery, or, I can't have surgery and I don't know what else to do. Now, for the people that surgery is an option, let's take a look at that for a second. And the first thing, there's 2 surgeries we're going to look at. So one is arthroscopic. So this is where they go and like scope the knee, clean the knee, different things like that. This is the number one surgery that's used in orthopedics is arthroscopic surgery for the knee. And what we see in this study is that the outcomes after arthroscopic lavage or arthroscopic debridement, so this is basically cleaning out the knee again, were no better than those after a placebo procedure. And in this particular study or in the next one, basically what they did was they compared it to sham surgery, where they went and made incisions so that they knocked the patient out. They made incisions in the knee. Half of the patients that got incisions, like half the patients just got incisions. The other half actually got the arthroscopic surgery. And there was minimal improvement from the arthroscopic surgery versus the ones who just had an incision in the knee. And so that's, again, arthroscopic surgery is not super great for osteoarthritis. This particular study shows that arthroscopic surgery showed no additional benefit to optimize physical therapy and medical therapy. Medical therapy being steroids, et cetera, Nsaids, all that. Physical therapy outperforms arthroscopic surgery, I'd say 90% of the time, and the other 10% is just more is needed outside of that. And so that's the data on arthroscopic surgery. The next one now is total knee replacement, and for total knee replacement, we're looking at interesting outcomes. So total knee replacement actually does a good job at improving pain relief and function, even after 12 months than non-surgical treatment alone. So this is actually a really good option. I do recommend patients do this when they hit that part where they're disabled. They literally can't do anything else. I'm going to go and recommend that they talk to a surgeon, because the outcomes for this are actually really good. It's the ones that aren't surgical candidates that really suffer. But people that are surgical candidates and that have severe osteoarthritis really benefit from a total knee replacement. Outcomes are fantastic. It improves pain. It improves function. And if you want to go, if this is something that people end up opting for, I do highly recommend that they do prehab, which is physical therapy beforehand, because it does improve the efficacy of the total knee replacements and their recovery. The downside to total knee replacement is that there's about 20% of people, so 1 in 5, that still have pain in their knee following a total knee replacement. And so there is dissatisfaction with the knee or with a total knee replacement in 20% of the population because they still have knee pain. And I've seen this multiple times, and we'll discuss what the options or what is happening in those cases. So just a recap of the conventional treatments. We're looking at a few different things here. So lifestyle, meds, steroids, and surgery can all decrease pain for less than 3 or up to 6 months. When we're looking at decreasing pain for greater than 6 months, lifestyle can do that to some degree. Meds, steroids can't, and I've messed up this. This is supposed to be a check mark, and apparently I just messed up this entire thing. So this is supposed to be a check mark here. Surgery can definitely help with that. Improving function, lifestyle, surgery can. I'm going to argue that meds and steroids can't, because ultimately you're not actually fixing the problem. You're just going to continue to make the problem worse should you not be able to feel pain and still do all the stuff you're not supposed to necessarily. You're going to cause more of an issue. Effectiveness improves per treatment. Lifestyle, obviously, yes, the more weight you lose and the more exercise you do, the better you're going to get. Meds, steroids definitely don't improve as the more you do. Surgery, hopefully you only have to do the one. So I'm going to put an X on that. Promotes healing. Lifestyle can definitely do that. Meds, steroids don't. Surgery does to some degree. And then the risk level. So low, what do you call it? Lifestyle is low risk. Meds are low to moderate, depending on the medication. Steroids are moderate, and then surgery is high risk, right? So that's the conventional treatment. So recapping the problem of conventional treatment is focusing on the wrong goals. So the goal, again, is pain relief. If you want more than pain relief, this outside of surgery and lifestyle stuff, you're not going to really get that. Treating with blinders, again, focusing just on the cartilage, except for the duloxetine, which focuses on nerves. Band-aiding the problem. So again, you're just band-aiding and getting them out of pain instead of fixing the problem. And then treating with outdated therapies. And this is where we're going and using therapies that like hyaluronic acid that are shown to not be effective, opioids that are shown to not be effective, Nsaids that don't really improve a whole lot outside of a temporary improvement, steroids that actually make the problem worse. They all have their cons to it essentially. So instead of focusing on the wrong goals, what if we thought beyond pain relief, right? So a lot of patients who are coming into us are wanting to not only improve pain, but function, stay active. How do they prevent this from coming back? Those are their goals. So when we're here at Ethos and we're looking at people finding a solution, or we're helping people find a solution for the conventional model, one of the first things that we start off is thinking beyond pain relief. Instead of treating with blinders, we go and consider all pieces of the puzzle. So there's more to osteoarthritis than just what's going on at the knee as well. You're looking at hip strength. We're looking at ankle mobility. We're looking at pelvic alignment, because all of those contribute to osteoarthritis in the knee. The knee is rarely ever the true cause of the problem. Usually there is a biomechanic problem that's going on somewhere else, and the knee is a victim of that problem. And so that's something that we really need to look at, and I'll go into that a little bit more. Band-aiding the problem, again, just using stuff to dull the pain. If we work backwards, which is using our approach of all the pieces of the puzzle, then we can really figure out, okay, where's the pain coming from, one, and then how did the pain get there? Like, how did this tissue damage that's causing pain actually occur and affect this patient? And if we work backwards, then we're able to go and figure out not only how to get rid of the pain, but how to, again, solve the whole puzzle and prevent it from coming back in the future. And then treating with outdated therapy, so using newer therapies that are designed to fix the problem rather than just band-aid the issue. That's our approach difference here at Ethos. And so we're going to go over that now and really dive into that. So this very first one, again, the Ethos approach to osteoarthritis, the very first step that we're interested in is understanding your goals. So again, a lot of times goals are going to be, sometimes we do get patients who just want to be out of pain, and that's great. But oftentimes the patients who are coming to us are those active individuals who are wanting to not only get out of pain, but improve their function, improve their range of motion, all that stuff. So what does defining success look like for us, and the goals that we use with our patients? This is what defining success looks like to us. So making sure the patient's out of pain, making sure their knee function and range of motion is fully restored, making sure the knee joint is stable, that the patient can safely return to activity. A lot of times you can just go, patients will go and they can start doing stuff, but then they're like, yeah, it still feels a little iffy. I don't want to put a lot of weight on it. I'm very cognizant of how I step. And to me, that's not safely returning to activity. I want you to not have to think about it, and really feel confident in that part. And then, do we prevent the injury from getting worse? So what are the chances of this developing down the road? So with this criteria, to us, when we are able to hit this criteria in every single case, or in a given case, that's when we determine that the case is successful. If we fall short of any of these, we consider it a failure on our end. Or if we don't know the outcome, so sometimes patients will just ghost us for whatever reason. And if that happens, a lot of doctors, when I talk to them, because it happens to multiple doctors, when I talk to them, they go and say, oh yeah, I just assumed that the patient got better. Well, we don't. We assume that they didn't get better and that we upset them or something like that. Oftentimes we end up finding out that they are better, but we usually assume that it's a failure because I have to physically see it and examine it in order to determine that it was a success. So with that criteria, we have a 94% success rate in treating osteoarthritis and helping our patients within our practice. So going on to step 2 of our approach, the second step is really assessing the problem. So I'm going to show you 2 more studies, and this is where we're looking at, again, the solving the puzzle. How do we take our blinders off and really assess what the issue is? So we're going to look at this research paper, and this research paper is called Sources of Pain in Osteoarthritis, a Pathophysiologic Review. And where I want to draw your attention to is this area here that says pain receptors have been found in the synovium, ligaments, capsule, subchondral bone, and surrounding tissues, with the exception of articular cartilage. Meaning, when we're focusing on osteoarthritis, we're focusing on the cartilage and that cartilage breakdown. The pain actually isn't coming from the cartilage. It's coming from the tissues around the cartilage. So the ligaments, the synovium, the capsule, the bone. And when you take your blinders off and really understand where the pain is coming from, you can have a better idea of how to treat it. Because how you treat a ligament is different than how you treat a nerve, is different than how you treat synovium. So those are different things that you have to look at, and different approaches. So really we have to understand where is the pain coming from, and we do that in our physical exam and through our diagnostic process. The other thing that I want to show you is a little bit more on nerves. So there's an article here that says, do we pay enough attention to neuropathic pain in knee osteoarthritis patients? And what they found was that from the people that they examined, 14.8% and possibly 24.6 or 25%, 1 in 4 of these people have knee pain that is going undiagnosed. Sorry, have nerve pain from osteoarthritis that's going undiagnosed. And so that's really something we want to pay attention to, because that means 1 in 4 people that aren't getting better, we need to consider the nerves. And that could be the rest of the problem, the rest of the piece of the puzzle. And so we really need to pay attention to that and understand that piece. So how do we approach it? We look at a few different things here. So the very first one is symmetry. So symmetry has to do with pelvic alignment. When you go to a chiropractor, this is one of the things that's being assessed. So we look at this as well, and we assess, okay, is your pelvis in line? Is your neck in line? What does the spine look like? If your pelvis is out of line, that can cause you to walk differently, which can then cause wear and tear on your knee. and that cartilage breakdown. So we need to look and see what does the symmetry look like? Are you in alignment? The next piece is going to be neuromuscular. So neuromuscular has to do with nerves and muscles. Oftentimes we get people who have arthritis, and a lot of times the arthritis can be caused from, or part of the contributing factor is that the muscles around the knee, so your quad, your hamstrings, all that are tight. And when they're tight, they're compressing the joint as a whole. If you relax those muscles, then, and there's multiple reasons why they're tight, but if ultimately, if you get the muscles to relax, it actually takes the pressure off that joint and decreases the pain significantly. And then neuromuscular, so nerves, is going to also be the neuropathic thing we were talking about. So there can be nerve entrapments around the knee that are causing this issue that we need to pay attention to. So we also assess for these things. Stability is the next piece, and stability has to do with how stable is the knee. So people end up having kind of a shaky knee when they walk, and by shaky, it feels shaky, like they don't feel stable on it, and that's literally the term that they use for us. And stability comes from healthy tendons, healthy ligaments, and strong muscles around the knee. And so if you ever have an issue where any of those are compromised, then you can lose stability in the knee, and that's something we need to pay attention to. And really pay and look for to determine if that's a cause of it. And then last one is articulation. So articulation is what's going on inside the joint. This is what's going on with the cartilage, the meniscus, the synovium, the capsule, all that stuff. And again, you can have any of these pieces have tissue damage that's generating pain signals. So when we evaluate all four of these things, we don't treat all of them. We refer out for people that are specialists in treating some of these. So like stability in muscle strength, we refer to physical therapy. We refer to chiropractors for symmetry, different things like that. And so we don't treat all of them, but we do assess all four to really determine what's causing the pain and working backwards from that, so that we can go and say, okay, Janet, if you have osteoarthritis in your knee with a meniscus tear, that likely came from a stability problem. So we need to fix this part first, and then we need to work on your stability. That stability was likely caused from a symmetry problem. So then we also need to have you work on that too. If we can accomplish those three things, the chances of this coming back are pretty slim, because we not only address the problem, but we fix the cause of that problem, which was these two things. So those are all things that we're paying attention to really come up with a comprehensive plan. The next step is selecting the appropriate therapy. So when we go and dive in, when we take our blinders off and we dive into what specifically is causing the pain and how did that happen? How did we get to that point? It really allows us to focus in on what therapies are best. Does the patient need physical therapy? Do they need chiropractic? Or do they need some of the stuff that we do? And based on the tissue damage based on the tissue that we're treating, that'll determine what specifically that we go and address. So this first treatment that we do in our office is called Perineural injection therapy. This has to do with treating nerve pain. And if you recall, there was we had a stat earlier that said if you 20% of people who had a total knee replacement still had pain after the fact. So this doctor went and looked at the effectiveness of perineural injections, which are a dextrose injection where you inject next to the nerves to clear up an entrapment. And when you do that, they found that perineural injection therapy, or PIT, as they label it here, is a promising approach in treating chronic post-surgical pain with minimal cost, simple and secure injection procedures, minimal side effects, and high clinical efficacy. So 20% of the people that are having pain after a total knee replacement is often a nerve-related issue. And using perineural after the fact can help resolve that issue. Now, I've had some patients who came in with a total knee replacement, had this problem. We were able to clear it up pretty quickly, but realistically, we could have cleared up the pain. At the end of the day, it was a nerve problem. So replacing the joint didn't do anything for them. They still had the exact same pain. So had they done this, they wouldn't have needed the total knee replacement. And so this is a really good therapy that we use. Side effect profile is practically nothing. because at the end of the day, you're injecting dextrose, which is a sugar, by the nerve, and it works to help regenerate the nerve. If we can do that, then and there is truly a nerve entrapment, we can actually heal the nerve and have the pain signal go away. So this is actually a long-term treatment. It does, the nice thing with this one is if it's going to work, we'll know within like 5 minutes because it works that quickly. And then we just do a few of them to kind of compound the effect. The next treatment here is prolotherapy. So dextrose prolotherapy. Again, we're using dextrose, which is a sugar. This time in prolotherapy, it's used at a higher concentration. What they did here was they looked at osteoarthritis and dextrose prolotherapy, and they found that prolotherapy resulted in sustained improvement of pain, function, and stiffness scores compared with blinded saline and at-home exercises. So remember, exercises did pretty well early on, and now prolotherapy is outperforming it. And then remember, we had comparisons of saline injections and hyaluronic acid, and how that didn't do anything. Well, this, prolotherapy outperforms it as a whole. It works by essentially addressing the cartilage, helping promote cartilage regeneration to some degree, and it really works on helping with improving the pain signaling that's going on in the synovium and kind of shutting that down. You can also use it to help improve the ligaments stability and the tendon stability around the knee. And if you can make the knee more stable, then the issue goes away. So using prolotherapy for osteoarthritis has great efficacy on that part. This other study was another randomized controlled study, and it again suggested that dextrose prolotherapy is effective at reducing pain and improving the functional status and quality of life in patients with knee osteoarthritis. So positive results with that as well. Platelet-rich plasma is another treatment that we use here, or PRP therapy. This study compares it to hyaluronic acid, and you can see that PRP offers obvious advantages in conservative treatment. It can reduce long-term pain, improve knee function with no additional risk, and therefore it can be widely used for the conservative treatment of knee osteoarthritis. And so it beat out hyaluronic acid, which again didn't show much on that piece. And then it gave long-term pain relief and function. So again, the goal here is improving knee pain and function. With another PRP study shows that comparing it to hyaluronic acid again, showed more and longer efficacy than HA injections in reducing pain and symptoms, recovering articular function. Better results were achieved in younger, more active patients, and I have found that to be true in practice. Typically, the more active somebody is, the better they're going to respond. In general, the younger they are, the better they're going to respond. But I've had people that are, I saw a patient today that's 87 and he responded to the treatments. So, again, it's really how is it done? There's more to it than just injecting into the joint space. So there's that piece, again, just showing that it outperforms HA. This one is the treatment of knee osteoarthritis, again, comparing it to HA. HA is kind of the standard one that they use in comparison studies, and shows that it's an effective and safe treatment. Further studies are needed to confirm the results, investigate persistence of beneficial effects. One of the biggest issues we have in regenerative medicine is that it hasn't been standardized yet. So a lot of people have different protocols, like even myself and some other colleagues here, how we treat is very different in some degree. So there's no standardization of protocols. And so that a lot of these studies call for more standardization to really understand, specifically, like in the case of platelet-rich plasma, how many platelets are in a given syringe, how many platelets are needed for osteoarthritis, where were the injections done. With hyaluronic acid and steroids, all you do is inject into the knee. With these treatments, some people will inject into the knee, some people will inject into the knee and on the ligaments. It just really depends. It's more of an approach as well that you have to understand. But again, it's showing positive outcomes on this part. So this entire process from step 1 to step 3 can take probably a max about a week. It really depends on it, you know, if you come in with imaging, oftentimes we can do stuff right off the bat. If we need imaging to confirm some things, then you know that's where it might take a week. So between step 1 and step 3 takes about 1 week. Between step 3 and step 5 is a 3-month process on average. So compare that to the 12 months it took to justify surgery in the conventional model. Now, some surgeons will go and jump that and just say, hey, you need surgery right away. I'd also be a little bit wary of that too, because you may not be like, you know, a candidate, or it may not be needed if you're not like super, you know, if your knee pain isn't that bad. Some surgeons are really quick to cut too, so I'd be careful with that piece. But in general, you know, you're going to take a little bit longer just because a lot of surgeons will take time to justify everything, which is good. You don't want them cutting right away if you don't have to. So tracking progress here at Ethos, we track our progress over the entire time, and then we really go and look at it from a. I follow all my patients for 2 years or longer. I try my best to do longer than 2 years, but some people, you know, move out of town, stuff like that, and so at that point, it's just follow up phone calls, see how they're doing. And then finally, returning to activity. And return to activity is the ultimate goal for my patients here. And can they safely do it? Can we go and make sure that they feel confident in returning to activity and that stuff? And so, you know, it's always like literally the best part of my job is being able to celebrate with people when they're able to go back and do stuff. Oftentimes, when we're tracking progress, they are still staying active. And when we're treating, they just might have modified treatments. But I mean, yeah, a lot of times they're able to stay active. And then again, I like to ask patients, well, you know, what is it is there a goal that you're shooting for? Like, do you have a height that you want to do? Do you have a certain golf score that you want to hit or something like that? And we're tracking that the entire time because I want to see if we can hit that piece. And so it's always great to celebrate that with them. So that's definitely like my favorite part of helping people at the end of the day. Next thing here, so comparing the conventional versus Ethos treatments. Again, I messed up the surgery part, so keep in mind, surgery does help improve pain greater than 6 months. It does improve function. But when you're comparing it to regenerative medicine, which I'm going to go and put the Ethos treatments in this, you know, they work on not only decreasing pain for a short term. Our approach specifically, and when we look at the whole piece of the puzzle of looking at stability, neuromuscular symmetry, all that stuff, our goal is to, again, make sure that this is a long-lasting thing that you're receiving. And so that's important to me. If we skip those parts, can we get people out of pain? Yes, but you know, there's a chance they might return 2 years later, a year later, and I don't want that. I want to make sure that we can get them better and continue to, you know, celebrate with them as they hit different milestones of activity. We're improving function with with these treatments as well. These treatments have a compound effect. So typically they require a series. So we do a series of them because each time we're doing it, it has this compound effect and they build on each other. So my average treatments are about 3 to 4 treatments for osteoarthritis. Usually patients start receiving pretty significant relief by the first one. Or after the first treatment, and then the rest of it's really just reinforcing it. Sometimes I need 2 to see a big improvement. But if I can get a patient like 50% better on the first treatment, like I'm super happy with that. Like I know that it's going to be a great progression. They're going to go through their progression really fast. We're promoting healing at the end of the day, so we're working on fixing the problem of tissue damage. And the risk level for this is low to moderate. I mean, and I really put moderate in there because like. There's a handful of things that can go wrong. Probably the worst thing that I've had happen to me, like knock on wood, is what do you call it? When a patient flares a bit, and so we temporarily intensify their pain, and then you know, they don't like me for a few days, and I always tell people they're probably not going to like me for a few days after the injection. But that at the end of the day, it's a pretty minimal. Like I haven't had a lot of patients who have flared. And worst case scenario, it does happen. We always have ways to backtrack out of it and to go and reverse it, which is great. And so the risk level really is low. Like in general, the worst that can happen is it doesn't work. But what, with the approach that we take and with how selective we are with patients on whether or not these therapies will work, it's, again, the risk level is pretty low. Going back to Janet. So Janet was kind enough to leave us a testimonial. She was able, after some treatments, and she outlines what she did here, she was able to go and train for that competition. This is her, I believe she took 4th in that, in that competition. And so, like I said, at the time, she was like 60 or 61. And so, yeah, she looks phenomenal for that. And, again, just like fantastic patient, fantastic case. Like, she went through her progression well, did all the stuff that we had asked her to do, got better fast, was able to train, and we got to celebrate this win with her at the end of it. So, never get tired of those stories. And so, yeah, so that's Janet's story. And yeah, that's everything I have for the presentation today. We will be taking questions, and if you feel that you can benefit from this approach, I do offer free 15-minute consults. There's no obligation for these. Like, literally, you can come talk to me. There are times where I'll tell people, hey, these therapies aren't for you. You should do this instead first. You shouldn't start with this. And then there's other times where it's like, yeah, no, this makes sense. Like, we should go ahead and move forward. And so, at the end of the day, during these free 15-minute consults, I take a look at the case. I try and give you an idea of what I think is your best, in your best interest from a healthcare standpoint, and what your goals are. And I'm happy to chat with people and determine what needs to happen in order to get you better. Yeah, and Olivia, I'll give it back to you for.
Awesome, thank you. Thank you, Dr. Matt. Round of applause. This was a really great webinar. Thank you for hosting it. It was honestly really eye-opening to learn about the process of conventional medicine, what that follows, and how regenerative medicine differs in treatment and timeline. And thank you so much to everyone for joining us today. Like I said, or like Dr. Matt said, we'll take a few minutes to answer any general questions you may have had come up from the webinar. So if you have any, you can type them into the chat. We'll be sure to get to them. I just wanted to take a moment to let you know, Dr. Matt is the host of a really awesome podcast, our Ethos Athletes podcast. So if you liked what you learned today and you want to learn more, I highly recommend checking out this podcast. And I put that into the chat below. So if you want to pull up that website, it'll bring you right there. He's got a ton of different topics. And if you're looking for a specific one, you can always reach out to me and I can help you find it. I'll send it your way. Again, if you have any questions, feel free to type them in. I hope you learned something new about osteoarthritis and the research behind different treatment strategies. And if you take anything away from this webinar, I really hope that you understand that if you are experiencing pain, you really don't have to live with it forever. There's a physician out there who will take the time to understand your specific situation and will work with you to create a solid treatment plan that's best for you and your lifestyle. So if you are interested in scheduling a free 15-minute consultation, you have more specific questions pertaining to your personal care, I highly recommend reaching out, giving us a call. We'll be happy to get you scheduled. Dr. Matt will be able to answer your questions and help you to navigate those treatment options that he kind of talked about today. So we look forward to connecting with you soon, and I hope you all have a great rest of your week and weekend.